So the topic of my report is modern approaches, as Dieter Hölzer announced. My lab is dealing with mostly bone marrow, its involvement in metastasis, diagnosis of leukemia and lymphoma, of course, the immune system. I will speaking about hematogeneous metastasis prevention, and during this speech, I will tell you about bone marrow as well. So, bone marrow is not only a primary lymphoid organ, as you will know, where B-cell precursors and many other precursors arise and maturate. It's as well a peripheral lymphoid organ where multiple lymphoid functions are realized. They are listed here. I will not repeat it. So one of the most intriguing features of bone marrow is that disseminated tumor cells can sleep in bone marrow for years and even decades without waking up and triggering metastasis in different organs. Finally, and that is well documented, fact that involvement of bone marrow is adverse prognostic factor associated with shorter survival, for example, in breast cancer. We recently received data in advanced gastric cancer. Presence of disseminated tumor cells is the only unfavorable prognostic factor. Later in my report, we will speaking about tumor-associated glycans and natural antibodies to them. Here I just mentioned that monoclonal antibodies to well-known sugar target in gastric cancer, SC1, can significantly diminish frequency of disseminated tumor cells in human adenocarcinoma, its detection in nude mice. So it's, yes. So last year, it was 70-year anniversary of Cancer Research Center. And it is a pleasure for me to mention some names of our famous immunologists. Gary Abelev, he discovered alpha-theta protein. Galina Deichmann studied natural immunity. Galina was probably one of the first researchers who paid much attention to bone marrow. It is one of her first papers in International Journal of Cancer in 1983, and in Russian journals it was published even earlier. She shown that allogenic bone marrow can prevent lung metastasis of aggressive sarcoma in serial hamsters. You can see that in the cases of bone marrow injection, number of metastases is mainly 0. Жанna a little bit mentioned these studies in her report as well. It was the experimental basis of clinical protocol performed in 24 patients with osteogenic sarcoma by our former director, academician Nikolai Tupitsyn. Results of the protocol published in the International Journal of Cancer in 1993 were quite impressive. 2 times reduction of metastasis. The conclusion was almost evident. Normal non-activated allogenic bone marrow cells may be used for suppression of metastasis development in about half of patients with osteogenic sarcoma. Then, effective adjuvant therapy appeared. So the protocol has been almost forgotten. And in our days, I shown these results to Robert Gale, and you can see the title of his article in our journal. But he noted, of course, that randomized study is necessary, and these experiments are now being performed in our Institute of Carcinogenesis and started from the very beginning in mice. Recently, quite new areas of bone marrow research have been arising. adopted transfer of bone marrow lymphocytes, bone marrow vaccination, intra-bone marrow injection of allogenic bone marrow cells, etc. We paid much attention to bone marrow immune system study. Our initial studies shown, for example, elevation of TCR gamma delta bone marrow cells compared to non-malignant disorders in children. Z levels significantly diminished in cases with hematogeneous dissemination. In non-small cell lung cancer, there is a significant relation of histological type of tumor to bone marrow lymphocyte lineage. T cells, CD3, dominate in squamous cell cancer and B cells in adenocarcinoma. New datum was received for perforin-positive lymphocytes. Its difference was significantly higher in adenocarcinoma for CD4 and CD27 lymphocytes. Levels of NK cells of NK cells and B1 cells in bone marrow were significantly higher in breast cancer compared to non-malignant mastopathies. Interestingly, and it's quite a new data, so bone marrow high B cell levels were related to prognosis. You may see that here follow-up was more than 10 years. In fact, it was unfavorable prognosis in situations with diminished B cell precursors, which is also very interesting. Why high levels of bone marrow B cells are beneficial for overall survival in patients with breast cancer is not clear right now. Beneficial for overall survival were also levels of CD38 B cells. Beneficial role of bone marrow B1 cells in breast cancer patients was near significant, near statistical significance. Sorry. Yes, significance. You can see that in this case we note difference in progression-free survival, not overall survival as in previous diapositives. I should mention that differences in PFS we saw for molecular subtypes of breast cancer, hormone receptors, and lymph node involvement. But for overall survival, just the data I mentioned above. So, prognostic role of bone marrow T cells in breast cancer patients was not as evident. Sorry for some mix. Positive role of CD4 cells was noted for overall survival. Lower levels, less than 60% of CD3 cells in bone marrow were better for progression-free survival. Sorry. And activated CD8 cells were more typical for better progression-free survival. So, bone marrow as a very important immunological organ is involved in the duration of breast cancer patients' survival. We might pay attention to the structure of bone marrow cells, both precursors and B1 lymphocytes, for increase it by different immune modulators or adjuvants to improve, elevate the percentage of prognostically involved cells. The question arises, what to stimulate? Of course, we should turn to anti-tumor immunity. The only way to specifically kill cells, tumor cells, which may become malignant is known. It is induction of apoptosis of those cells with natural pentameric antibodies directed to tumor-associated glycans. This slide shows how it is realized. Anti-glycan antibody binds as well lipids. Complex dissociates in cytoplasm of glycan-positive cells, and cells die via so-called lipopaptosis, so to say, obesity. It is easy to stimulate natural. It is not easy to stimulate natural B-cell immunity. We analyzed several immune modulators and choose azoxymer bromidum, i.e. polyoxidonium. Some information about it is in the papers in Frontiers in Immunology, which are in your which was distributed before this section, and one of the most important reports you may see in our journal in English. The medicine was deeply investigated for adjuvant properties according to European guidelines on immune adjuvants. It is allowed to as immune modulator and immune adjuvant in the family of vaccines Gripol. You may see it at FDA website. Yes. And at WHO, at FDA and at WHO. Okay. Okay. The interesting features of polyoxidonium, which may have some relation to natural B-cell immunity, are as follows: restoration of immune response in old mice, augmentation of antibody synthesis in weakly responsive mouse strains, conjugate of PO with HSP40, augmented antibody synthesis up to 40 times. In clinical studies, it improved quality. Sorry. Yes. Yes. In clinical studies, it improves quality of life of cancer patients, proved safety and no accumulation in colon cancer and lung cancer, and indications for its use are before, during, and after chemotherapy, X-ray therapy, surgery, diminished immune suppression, hepato and nephrotoxicity, correction of immune deficiency. In 20 patients with operable breast cancer, we estimated pathomorphosis after PO. Not only pathomorphosis, of course, but it was as well done. Usually it was slight. But in one case of triple negative cancer with high proliferative activity, 75%, no tumor was not found after that therapy. I'll show you that pictures. Of course, it's just one case, and just I will show you that pictures. Initial core biopsy, invasive cancer, after PO. You see? No cancer, dense lymphoid infiltration, non-necrotizing epithelioid cell granuloma, many giant multinuclear cells. Here you can see BT and CD68 forming granuloma, CD8 granuloma forming positive epithelioid histiocytes. Now we come to the last slide, Dieter. Yes. So, come to the last slide. And conclusion concerning immune prophylaxis of cancer. This slide was demonstrated by Professor Margaret Hufleit, Poland, at our last conference in Tbilisi. She received that data during her work in New York. Green arrows show time when cancer was diagnosed on the basis of anti-glycan composition, and red arrows shows times of real diagnosis of cancer by standard methods. The interval between these two diagnoses is 2-5 years. So, during that period, it seems rational to try some adoptive immune therapy to restore natural immunity, which may be of help in killing potentially malignant cells. That is the concept of immune pathogenetical prophylaxis of cancer. And before this conference, I wrote to Robert Gale, and we will discuss later on during this section maybe it's worth organizing some group on natural immunity study against tumor-associated glycans, because it seems might be very interesting in cancer immune prophylaxis. So, thank you for your attention.
Very interesting. How do you identify patients who may develop a cancer and to interfere with your anti-glycan therapy?
You see that now there are some, so to say, technical approaches to do so. There are so-called, this is done on the slides, where about 600 of different glycans may be put. And then, sorry, may be put. And then it's, then there is a serum of patients or people can put on that slides, and then we will measure the intensity of each anti-glycan antibody signal. So, and it's not simply a diminution or a rising of some anti-glycans, but sometimes it's called as signatures, when composition of 5, 6, 7 anti-glycans become diagnostic for this situation. So such a concept. Okay. Okay.